and show you examples before I turn this over to Nettie of some of the work we have done at the Medical College of Georgia on partnership. And we believe you have to partner at all three levels. At your institutional level, your governance level, the level of your senior leadership and management of your organization, at the program level where you're building a program like neurosciences, or maybe it's a primary care clinic, and then at the level of the care, day in and day out, 24 hours a day, 7 days a week, every patient, every family, every staff member should experience patient and family-centered care. So here's some examples I want to show you. At the institutional level, you can use an advisory council, or you can have some patients that are placed strategically on committees. We happen at this point in our organization to have patients on all our quality and safety committees throughout the organization. But you can start with patients in just one or two places to start this work. I'm going to show you what our patient advisors helped us to understand about medication errors, what they meant to them, and how that changed our nursing practices. And I'm going to show you our behavioral standards for everybody in our workforce that our patient advisors helped us develop. Now, in 2005, we gathered our patient advisors together. They were from all walks of life in terms of experiences as heart patients, cancer patients, neuro patients, or family members. We spent about 2 hours really probing what did they think about medication errors. And these were the things they identified. And this was before the Joint Commission came out with its medication reconciliation requirements, actually. The need to have a list of medications that goes with you wherever you go, and it should be complete, and that many of us do experience errors, medication errors. About half of our patients in that particular session had experienced a medication error. And in the hospital, one of the biggest ahas is we do not know what we are taking. We go to the outpatient pharmacy, we get our medication, we get a lot of information, we know what we're taking. But in the hospital, what do we know? Do we know the different medications we're on? And what we found out was no, we don't as patients. We need an advocate. We're not in a normal frame of mind when we're hospitalized. That is so important to understand. We try to give discharge information or lots of education to people, and when they're in a condition, they can't readily accept it. So that's why they need an advocate. We need and want a lot more education on what we're taking, why we're taking, what are the side effects to look for. And we know our clinicians don't always understand all the drugs that we're on. We know that as patients. We want to be much more proactive in our care, and we understand it isn't realistic to think the healthcare provider can be all-knowing all the time. So help empower us with our own information. We know we need to use a single pharmacy that reduces errors, and we'd love to have a single knowledgeable pharmacist if we could to help us. And we need an ongoing list of our medications. We worry about being disrupted when we're on a medication routine when we go into the hospital. And a lot of times in the hospital we worry about the unstable diabetic, but we need to worry just as much about the stable diabetic who goes in and has the food and the insulin routines disrupted. And you've got to give us legible information on discharge. We need to have much clearer. When we get home, we've forgotten half of what you told us, and so we really need things to be a lot clearer. We know there's a risk that folks are not going to recognize drug interactions across settings, and we want you to be open about being questioned about what we're on. If we say we're not sure, that pill doesn't look right, check, please check. So what happened after this occurred? Our nursing leadership changed their practice at the bedside on distribution of medications. And these are some of the key things that they did. Opened the medication at the bedside in the presence of the patient. And this, again, before the safety goal of the Joint Commission came out on checking that patient identification, this was something that our patients asked for. That the patients told what they are taking and why, and if we questioned it, please double check. And every time, let's review these meds. What was interesting to me a couple of years later when we looked at our HCAHPS scores, and many of you are probably familiar with HCAHPS, which is the publicly reported patient perceptions of care, now on the CMS website. On the question related to talking about communication about medications, we found that our responses for our patients for that question were significantly better than our average for all other questions. And so our work with listening to patients about what was important to them had clearly paid off. Now here is another set. I'm not going to go through all these standards because we don't have time, but patients and families helped us to develop specific standards, behavioral standards for our staff for patient and family-centered care. And I've given them to you. You have them available to you. And what is it that our staff do that will make patients and families feel that they are true partners in care? Well, these are the standards. Involving patients and family and planning for the delivery and evaluation of health care, recognizing families who, as we define them as patients, to be important members of the team. That's why getting rid of visiting hours is so important. If patients and family members are true partners, then they're not visitors, and we have to eliminate this notion that we have visitors in our healthcare systems. We have families and we have partners. Supporting patients and involving their families in ways that they choose. And I'll just touch on one on this slide. Welcoming family members at all times, regardless of rounds, change of shift, or other events on the unit. That's for our convenience. Those things are in place for the convenience of the system or the convenience of providers. Care needs to be built around what's convenient for patients and families. Make it easy for patients and families to ask questions. It's one thing to allow a family member to participate, but it's a whole other level of involvement when we welcome their participation and say, what else would you like to have happen in this healthcare experience, patient, and how do you want your family involved? And, you know, providing emotional support. We know that is key to healing, and we have so many different ways that we can do that in our healthcare experiences that we offer. Okay, now at the program level, what can you do? And I'll just give you a quick couple of examples. This spring, we engaged a group of physicians, patients, nursing staff, administrators in creating a new vision for emergency services. We'd had a hard time really focusing on the experience of care there. And so we brought together this group, and they developed priorities together. I love this picture because right here in the center is our patient advisor, Christine Abbott. And she has the full, undivided attention of Dr. Richard Schwartz and Dr. Wiles. Dr. Schwartz is the chairman of emergency medicine. Dr. Wiles is the chief of pediatric emergency medicine. And after this happened, they really began